dystrophy, which is what it's been called for 100 years, and then they have to change names. I don't know how many years, but as long as I have called it, that's what I call it, reflex sympathetic dystrophy. So I'm trying to remember complex regional pain syndrome, which actually is a better name for it, by the way. There are other names for it: Sudeck's atrophy, minor causalgia. Remember, algia is pain. Atrophy would be a decrease in muscle bulk. Post-traumatic neuralgia. Shoulder-hand syndrome is a real common part of it when it has to do with a stroke shoulder and hand. So you'll hear that with a stroke. Reflex neurovascular dystrophy and causalgia. And so these are just different names for it. It's really kind of a weird deal when it happens. Characterized by pain in an extremity, usually an ankle or a hand or elbow. I've seen it in people with across their shoulders. I think that's really all except ankles and hands. But and sometimes up in the arm, like really in your extremities is probably kind of your distal extremities is the most common place, but I have had a lady that had it across her shoulders. It's associated with autonomic dysfunction that occurs following an injury to bone or soft tissue. It is most characterized by non-protected, non-functional pain. So they have this pain that's just, you can't figure it out. Why do they have this intense pain? Usually it starts out with just like a hypersensitivity. So we're going to look at the 3 stages of it. Type 1 is if it follows some type of orthopedic injury but not a nerve injury. And type 2 is when there's actually an injury to a nerve. So again, you mainly see it in ankles and wrists and hands, and you just have to really be aware and watch for it. The symptoms that you see, and again, some people have these and some people don't have them, and so it's just kind of a weird deal. When it gets severe, they get all of these. Burning pain, hyperalgesia, which is an increased sensitivity to noxious stimuli. Allodynia is pain provoked by stimuli not usually considered painful, such as just someone lightly touching you, bumping into you, clothes, like your clothes being on your body. Have you ever hurt so bad that when you had your clothes on, you could feel it? That's what this is like. They do have paresthesia. So what's paresthesia?
Is it not being able to feel?
Yeah, not being able to feel. Cyanosis, coldness or dependent rubor of the skin, and so they start having discoloration, a lot of paleness. They have cyanosis would be blue, where they turn blue. Have you ever seen modeling? Modeling, it's kind of, you actually see it in people that are dying, by the way. It's kind of a weird deal where their skin has, it can have little bumps in it. It doesn't always. It has discolorations where there'll be dark spots and light spots, and so that's what that is. Dependent edema, what does that mean? What's dependent edema? It's where if they hang the leg down or the hand down, it will get swollen. So that's why you elevate a stroke hand, because dependent is when it's hanging down. Altered, increased, or decreased perspiration or sweating, so they may sweat more on that extremity where they have it, or they may not sweat at all. Abnormal or changes in patterns of hair growth. Atrophy of muscles. Osteopenia. What's osteopenia? Penia is a decrease. Osteo is bone. So you have a decrease in bone. You actually have some issues with that. And then they develop contractures. And so these are just different things that can happen with them. What we want to do, though, is stop it at stage 1. Stage 1, they have localized pain, the allodynia, they have edema, vasomotor spasms, and pain with initiation of movement. So you start to see some weird sensory stuff coming on. I think I've been treating this lady's hand. I don't know if y'all have seen her come in, but she's a friend of mine, Cheryl. And I was very concerned about her because she came in and what happened is she got her cast off, and the doctor told her she could do anything that she felt like doing. And I think I told you she drives this, have I told you all about her? Maybe I did the first year class. Anyway, she drives this motorcycle, it's huge. She's a big lady, but I mean, it's just heavy. I used to remember thinking, she's gonna kill herself on that thing. But she got on it and drove a pretty far distance, like all the way to Muldrow or somewhere, and used that hand that she had just, I mean, it was broken on top of her. It's one of her metacarpals that was broken. But went in and used that hand all the way, like she drove like an hour, it may be longer, with it right after it came out of the cast. So I just want you to tell you, patients do crazy things. And what she said to me is, he told me I could do anything I wanted. I said, oh, I don't think he thought about you doing a heavy motorcycle, having to, I mean, think about what she had to do with that hand. It was I guess it's the gas, is that the gas on that side? And so she literally had to hold that consistently to even have control of the motorcycle. So her hand never rested that whole hour, right? I mean, it was always in some kind of isometric contraction, even more than that probably. Anyway, so what I was very concerned when I first saw her, because she was sensitive even to me to touch her. She was holding the hand funny. You never want to allow people to hold their hands like this. If you have a shoulder patient that comes in and they're doing something weird with their hand, you tell them to stop it. You don't want stroke patients to hold their hand like this. Why? Why is that? What are you mentally doing when you're holding your hand like this?
Guarding.
You're guarding, but it's an abnormality, and it looks what? Like the hand is really sick. We always put our hands in a weight-bearing position. Look at your hand. Do any of y'all have your hands up like this? You're always in a weight-bearing position. That's normal. So you always make them turn that hand over, get them out of the sling if they're doing weird things with it. I mean, it's just the way that this stuff develops. So they have these vasomotor spasms are responsible for causing transient unilateral temperature and color changes in the affected limb. So literally you're having some vascular things that are weird. It's just starting to cause issues. This stage may resolve with intervention or degeneration to stage 2. What would be intervention if you were going to guess? What would you do? What's the first thing you tell them? You don't want to scare them, but you want to change whatever they're doing, that pattern. So what I did with her is I told her things I wanted her to do at home. I wanted her to get some analgesic cream and start rubbing that hand, just so she's aware of it. She was holding it like this, so I made her start. I said I want it in weight bearing, wherever you're at, it needs to be down. Make sure you're down, because weight bearing is normal. This feeling like this is normal on a foot. What's normal on a foot? Have you ever had your feet hanging out in space for like an hour and gone to sleep? What does that make your feet feel like? Is that not weird when you put your feet down? Mm-hmm. That's not a healthy thing. So years ago, they used to put people in traction, and they put them up, where they put that foot up and just let it hang there and just hang down. And they leave them like that for 6 weeks. People were in traction for 6 weeks in hospital beds. Did y'all know that? But when I first got out of PT school, which was 100 years ago, I realized, but they did that. And they had tons of problems with this. This was even more of a problem. So always, it's very important for people that are in any type of orthopedic injury, whether they have external traction or anything like that. They have external fixators now usually, if you've seen that, where they have the metal sticking out of their bone, basically that's, you want to make sure they're wearing a shoe, or they have some type of push into maybe a wheelchair, the foot plate on the wheelchair, but they need input into that foot. You do not want that foot to hang there. That's going to lead into this. Normal input is to have your foot feeling something on the bottom of the foot. It's very, very important. But that's also true with the hand, that it does natural things. So what I told her to do, first I educated her. I told her I was very concerned because we're actually going to talk about hand rehab today. So one of the things that with hand rehab if you don't learn anything else, know that if you have an inflamed hand, you do not treat it. You do pain modalities, but you do not do any type of strengthening. So you might sit out a total of 3 weeks if they're inflamed. So if you inflame them doing too much, if you overdo on a hand, you literally could lose 3 weeks of therapy. And you might as well send them home. Have them do pain stuff and do not touch them again until, just have them do basic range of motion, easy stuff, and just let it rest. That's what you have to do with the hand. It's very, very important. Because you literally can overwork a hand very quickly. So it's very, when you're doing hand therapy, it's always better to do less than more. So she came in on Thursday, and I didn't do anything with her. We just taught, I did have her get a wrist support brace so that she could wear a brace at night because it was hurting her at nighttime, just so it would rest. And also I had her start doing this stuff. I had her put her hand in hot water and do all her range of motion in hot water. She didn't have full range. She couldn't get her, she had lost, she couldn't bring these 2 fingers down like this. She lost it, she couldn't do a grip. So anyway, just to give you some ideas. So we want to stop it in stage 1. First off, you need to recognize it and the possibility of it. Again, where you see it is fractured ankles. And it's real common with fractured ankles to let that foot be without some kind of shoe on it. At least they need a sock on, but they really need something on the bottom of the foot. So even if they have to get a house shoe that's way too big because the ankle's got all this swelling or whatever, get something on the bottom of that foot, okay? So if we go on to stage 2, the pain becomes more diffuse, constant, and exaggerated. It goes from being that one little spot to the whole hand or the whole arm. It just diffuses everywhere. Poor circulation is evident in decreased hair growth, increased edema, and drawn, shiny skin. Muscle wasting becomes more evident. Treatment can limit this stage but may progress to stage 3. When you're in stage 2, it needs some intense things. Usually once they if they recognize it soon enough, if a doctor recognizes it, they're going to send them to a pain clinic. They're going to look at doing injections with them to get that pain level down. Sometimes that works. To do, what are they called when they give you, like you're getting surgery and they give you the thing so you don't have any sensation? It's not an injection, what is it? Epidural. They might do some epidural work to get that pain level down. So that's just some different things. They do try to treat it differently and try to recognize it. Stage 3 is pretty bad, and I'm going to show you some pictures of it so it'll scare you. Joints become ankylosed. What's ankylosed? Bent and stiff, very bent and stiff. With severe osteoporosis and edema, pain may or may not be present, and you have severe atrophy in the muscle. So this is really a bad place where they're going to be disabled in that extremity. You're not going to come out of stage 3 very easily. If you can at least stop it at stage 2. So some of the treatments that you can use, I've had really good luck with kinesiotaping because they have all these weird sensory things going on anyway. And so we haven't really done any kinesiotaping with you guys because you haven't been in the pro bono lab, but we really need to get in there and play with that. So I need to talk to Kendall because I'm telling you, I love kinesiotaping. Reason being is it gives you an option for them to do on their own. It is very effective, and I've had good luck with it myself. I mean, it's just amazing what it can do. And the first time I ever used it, well, I took a class, but I had used it a little bit before. I had a friend who had a fractured ankle, and they could not get the swelling out of that ankle. And of course, she was up walking on it quite a bit. And we just you don't need, kinesiotape, less is better. You don't want to put a bunch on there. And we did 2 pieces of tape around that ankle, and then on both sides, like one piece on one side and one the other, and her, literally, when I saw her the next day, her swelling was completely gone, and she had not changed her activity. So it was really significant to me. Did Kendall ever tell you about what happened with theirs, or did I tell you about the ACL person? Kendall and Bill, when we first took this kinesiotaping, and this has been years ago, 10 years ago, They were both skeptics. You know how skeptical they are unless you prove something to them? Have y'all figured that out about them? Well, anyway, they were both skeptics about kinesiotaping, and the girl who taught us was actually a massage therapist, so they were even more skeptical. And so she came in, and we had just had a basketball player who had an ACL injury, had ACL repair. And literally, like it was the next day, I believe. It might have been 2 days later, but it was the next day. And the girl said, the teacher said, well, bring her in, and I'll show you how significant kinesiotaping can be with edema. And so here the girl came in on crutches. She was non-weight bearing. She had a long leg splint on and to protect the ACL. And so they removed that. Kendall, I believe, was the one who measured her. He measured her for edema at the ankle, at the calf, at the knee, and then 2 places at the thigh. And so he measured her. Well, then the girl did the different type of kinesiotaping for the swelling. So it has kind of looks like a snake type thing. He hasn't done that with y'all at all, has he? Kendall is so good, and he's very artistic with it. Bill probably is too, but Kendall's are pretty. And so she did that with that girl. And so then they sent her out, told her to do normal activity, and of course she went out and was up on it. She didn't put her leg up at that time. She was up on it. And so she came back 4 hours later, and the edema in that knee was minus like 2 inches. It was significant, decreased 2 inches. So that's when Bill and Kendall became believers. So we were so glad. But anyway, it's really neat. So we need to spend some time doing that. I do kinesiotaping more for pain than edema, but normally. But anyway, okay. So PT treatment and management for this. TENS, biofeedback is good. Desensitization, what does that mean? What would desensitization be? We talked about this with scar problems.
Start touching it more?
Yeah, you start having them rub it. If they're extremely hypersensitive, you might start with just a piece of cotton and just going up, touching them with cotton or letting them do it. I'm pretty much into letting them do it because then they have more control. They're so scared sometimes of you doing it if they don't trust you. Then once you get to a cotton, you might go to a real soft cloth, and then you might go to one of those rougher wash rags, like a rough wash rag, and rub it with that. And then they might let you start doing some heavy massage if they can tolerate that. And so you start with very soft things and you move to harder things. And one of the hardest things for like a hand or an ankle is to put that down into sand and work in sand. That if they're hypersensitive, with all that touching at the same time, that's very hard for them. So when you get them to where you can put them in sand, it's really neat. They're at a point. But anyway, that's desensitization. You start with something that's very soft and something they can tolerate, and you move to harder things that you're touching them with, okay? Thermal modalities would be ultrasound, anything. If you want to make sure you don't burn them, because they're not going to have normal sensation, so just be aware of that. Whirlpool is very helpful. Whirlpools, getting in the water is always good. Passive range of motion, active range of motion, of course, and then muscle strengthening down the way. And then the most important thing for the ankle is weight-bearing activities. But what happens if you can't bear weight on it? You're still going to put pressure into that ankle. You're going to do some kind of pressure into that ankle, like a shoe, just something to put sensation on the bottom of that foot. A shoe, again, if you're in the wheelchair, you can make sure that the foot plate touches that foot. You don't want it just hanging there. You want to make sure the foot plate touches it, that kind of stuff. And then kinesiotaping. Okay.